is good? This one? Okay.
No, they didn't. I'll put up the Downstate logo. So, here, let me give you mine. Yes. Do you have any audio? Any video? And this is going to be you right here?
That's her. And then I'm going to be with her. I'm going to...
So the two of y'all speaking together?
Yeah, we're going right into it. These are the slides for both.
Okay, okay. That's the only one.
Could you just click it on so I make sure?
Sure.
Yeah, that's it.
Okay. Do you have any audio, videos?
No, just kids. Okay. But not audio.
What happened?
So it's going to be... So this is the one I'm doing in this room.
Okay, so I'll transfer it here.
Yeah, let's put it on here.
Yes.
And then the other one I'm doing in the other room.
Okay, and this, which one are you, this is you here?
Yes, that's me here, yes.
Sagar?
No, I'm Manish Gar.
Okay. Right.
be speaking in the other room?
Like now, 11:15.
All right, so I'll come get
Basically,
you.
what'll happen is it'll be like 11:15 to 12:15,
And then you'll be
and
over.
then I'll come over here. These guys will already be speaking, and I'm the last guy.
Okay, so I'll come and set you up over there also.
You have your pill bottle, text the number and say, okay, how would you just text the number and say, and they'll text you back and they'll say, when the how long, suspended residency as and send the residence no concern about safety of him. They're also there with the family. So they're happening.
You have any audio or sound?
No movie. This is going. So out of our 16, only 5 of us got the fellowship, and all the 14 didn't even apply.
Bhakti didn't apply, Lorenzo didn't apply. Well, you got the email, and I even sent you a template. That's fine, it makes it more exclusive.
Yeah, but I feel they should do what they're.
Okay, this is your talk.
Okay, yeah.
So let me give you a flash.
Does it look nice when you load it? Because it looks.
Yeah,
because
it's two different screens.
Okay. See, like the name shifted to one side. That's not how I made it, but that's fine. Okay, I think it's the only slide where this happened. You get one hall started, we'll get this one started.
And this is it here, right? There you go. Well, if that's easier. I can give you 2 mics if you prefer that.
Do you want to do one at a time at the podium and then both of you sit at the table for questions, or just stand here?
So this one here, yeah, that's on already. And then I'll turn on a second one. Yeah, because that one is linked into the system here.
Oh, that's for recording.
Yes.
Okay. They're not going at once, but at the end.
Test 1 2 1 2. So I'll leave it on, and then they can just pick it up.
So you'll set it on the table until then. Okay. All right, we're going to get ready and get started. Yep. Welcome back, everyone. I think we had a really good start to the day. Really excited for the second half of the morning programming. We're going to be talking about pros and cons of short-term global health missions during this session. And I'd like to introduce our 2 speakers for this session. Judith Lasker. She is a distinguished professor in the Department of Sociology and Anthropology at Lehigh University in Bethlehem, Pennsylvania. Her focuses and areas of interest are in medical sociology, focusing on women's health issues, and in international health. She's recently written a book in 2016 called Hoping to Help: The Promises and Pitfalls of Global Health Volunteering, which is intricately related to the topic today that we're going to be discussing. And our second speaker is Jill Rothman. She's a director of the Medical Student Global Health Programs and an associate director of the Global Health Center at Einstein College of Medicine, very close by. And she runs a global health conference. The next one will be actually in December, which this year's topic is actually going to be talking about One Health, so talking about all the aspects of health, both environmental, human, animal, all the components, how they're interrelated, and how all those components are important to treating patients and healthcare approach in general. So I hope you all will look out for that conference. It's open to everyone. She'll be able to give you some more information as the year goes on about that if you're interested. So please welcome both of our speakers. Thank you very much.
Thank you. Thanks, Christina. Thanks to Stan especially. You may have caught, some of you, when Christina said, I work in Bethlehem, Pennsylvania, that so does Stan. And it was just this weird coincidence that I read the article that your organization put together on guidelines, and it said, contact person, Bethlehem, Pennsylvania, St. Luke's. I'm like, that's down the street. So I was very happy to meet him and Rich Sharp, and then to be invited to speak here. So I'm going to talk about the work that I did, the research. I'm a sociologist. I have no medical training, but I've always been interested in global health and taught about it, and I've worked with a lot of students who've done overseas volunteer trips, and I started asking questions about, okay, what's the good, the bad of these missions, short-term missions, and I will share just a little bit of what I learned when I started asking that question. I particularly am appreciative of the organization because the way I got introduced to it was through the guidelines that you've established for best practices. And this is something that, as I have worked in this area and met many people across the country working on best practices, I'm really happy to see that there are organizations that are really working hard to try to eliminate some of the pitfalls and promote some of the best ways of doing global health. So this is my latest favorite picture of some of the pitfalls. Anybody know what this is? What is this picture? Anybody recognize it? Sona, what is that?
Elon Musk's trial to get
Exactly. This was the Elon Musk, I don't know what he spent in the millions and millions of dollars to create what was supposed to be a child-sized submarine. I don't understand how a child could fit in here, but okay. And he flew to Thailand with this fabulous piece of equipment to try to help rescue those children. And it was a, very motivated investment, motivated by all the good will imaginable and all the money possible. But when he got there, the British diver who was the head of the team said it had no chance of working. They had no conception of what the passage was like. And then the New York Times article about this basically said it was nice, but impractical, and Mr. Musk was really more than pissed off. I mean, he put out some Twitters about the diver, and so why do I bring this here? Because unfortunately, some of the best-willed international mission programs are a little bit like this. Very expensive, high-tech, highly motivated, well-meaning, and useless. Or in some cases, harmful, which is even worse. So, as we become more aware of this, and we are becoming more aware of this because of this, what some people call a tsunami of volunteers, the demand for global health opportunities on the part of not just medical people, but people. Church members, teenagers, you name it, there's people wanting to go overseas and do good and save the world, well motivated. Billions of dollars are being spent in this effort. Thousands and thousands of organizations have risen up, and some of you are very familiar with some of them, to do good work overseas. So who's sponsoring these missions? The most common are faith-based. So your realm is the medical world, but you are part of a much bigger phenomenon, and the dominant is the church groups. Many of you may have gone with church groups who go for a week or two to somewhere where they know somebody and bring some medicines and do some church work. Some of these are really good, some of them less so, but that's true of all of these. Lots and lots of NGOs. Corporations are doing overseas global health missions. And then there's the private sector, which is growing enormously and recruiting people to go on trips, and they're doing it to make money, and their desire to worry about best practices only goes so far as what they think they need to recruit people, and that's an unfortunate thing. Many high schools are now organizing trips, definitely college undergraduates, and then all of the graduate schools. So again, this is growing. So it's, the whole notion of a global health program, as we heard from the earlier speaker, Dr. Gorgas, was practically unheard of 10, 20 years ago. And now every medical school just about is talking about or has a global health program, as do dental schools, nursing schools, midwifery schools, pharmacy schools, veterinary schools. It is, again, a growing phenomenon. Okay, and it's not just in the US. There are many countries around the world that are sending volunteers. I was involved in a study where the majority of the volunteers were from Korea, going to poorer countries. So at the same time that we have this huge increase, we also have a growing critique. And a lot of it is on social media. Have any of you ever seen Barbie's Savior on Instagram? It's very clever, right? It's a sarcastic take on the white savior, Barbie who loves Africans, has no knowledge about Africa, but she's going to go play with orphans and make the world better. And it's cleverly done. But there's also a lot of, blogs being written, websites, Facebook pages, and more scholarly literature that is beginning to ask questions about the value of this volunteer effort and questions about, how could it be done better. So I forgot I wanted to show you a really brief video. Can I do that? Can you put me, I forgot to ask you, can you put me on the internet real quickly to show this video? So I wanted to show you two things. In this world that you are practicing in, the appeals to people to volunteer are everywhere. And the picture on the left is from one of the many, many, many organizations that recruits volunteers to do service projects abroad. This is a medical internship in Kenya. What does it look like is going on in this picture? What do you see in this picture? Yeah.
Do you want us to go to alexsmith.com?
Please, please. Yeah, it looks like she's treating a wound or something like that. Now, maybe she's a doctor or a nurse, but this is a project that advertises no requirements whatsoever. Anybody who can pay the fee is welcome to come on these trips. So a lot of the issues around global health projects is people, okay, so we're going to go down to the bottom, and this, I just wanted you to see what you think of this video. Keep going. Nope, all right. Go up a little bit. Keep going. All right, so watch the sneak peek video, that's one. So this is one that I came across, and that is an appeal to high school students.
My junior year of high school, I knew that I wanted to do something in medicine. And I was looking around, but everyone was always saying, no, you're too young, you're not ready for this, you don't know enough. And I was feeling very let down by the world, thinking, I love medicine, and I know that I can do this, and I want to do something. I came across this program, and I couldn't believe that something like this actually existed for high schoolers.
I got to experience virtually every aspect of medicine. I toured with doctors in neurology, cardiothoracic surgery, peds, orthopedics surgery, and I got to see various aspects of medicine. There was surgery, there was patient interaction, there was diagnosis, there was everything.
I'm kind of somebody who's generally confident, but also, you know, I like to stay back a little bit and kind of see what's going on. But with this program, there's a lot of opportunity to get involved in ways that I usually don't push myself to do.
The first day in the hospital, I was on a surgery rotation. I got to see 9 procedures in one day. And there's a patient on the left on the table getting a vaginal hysterectomy, and a patient on the right getting an abdominal hysterectomy. And he's walking me through exactly what he's doing, why he's doing it, the patient's story of how this happened. And he said, go ahead and feel in and feel the fibroids on her uterus. So I actually got to touch the fibroids in this woman's uterus on an OR table at 16 years old.
2 patients consecutively came into the ward and were 10 centimeters dilated, ready to give birth right then and there. We all scrubbed in, we all had gloves on, the doctor was really hands-on with us. She literally grabbed me by the scrubs and pulled me over and said, deliver, deliver. And so we guided the baby out of the birth canal, and then I handed the baby off to one of my group members, and then they cut the umbilical cord, and then there is a group right next to me doing the exact same thing.
So I watched as they did the C-section. They cut through the abdominal wall, they cut through the uterus, and then when they pulled the baby out, it hit me like a bus that this is what I meant to do for the rest of my life.
I'm really thankful for having had the experience, not only because of the medicine, but all the great people that
Yeah, HIPAA violation, but it's in another country. And in fact, the advertisement on this website specifically say, go on these trips because you can do things that you can't do in the United States. You are not allowed to do in the US. You can go to, and they have a bunch of different countries they go to. They're not all the low-income countries. There's Mexico, and I think there's one in Poland. And basically, for $6,500 as a high school student, you can go for 2 to 3 weeks and have this kind of experience. And they do a lot of cadaver work as well. So they have the students dissecting cadavers as well as what you saw. And they are promoting it as a way to get more people involved and interested in medical school. So and I had a chat with them when I was online. They come up with a chat like, oh, how can we help you? And I sort of made up a story about my niece who's in high school. She's not a very strong student. And do you have a GPA requirement? No, no requirement. Do you need letters of recommendation? Nope, just fill out the form and send send the money in parentheses, in my parentheses. And I was like, well, she's never been out of the country before. And she's not a good student. Well, great, because we will supervise her completely, and this will help her get into medical school. This will help her get into college, and it will help her get into medical school, our 3 weeks. Now, if I were a parent who really wanted their kid to go to medical school, and the kid wasn't sure, and I had $6,500 to spare, how many of you would have considered this? Those of you who are residents, right? It's tempting. But this is the world that is out there, and you know, I'm glad that there are people like you all who are trying to improve it, but I think it's important to keep in mind that many students who apply to medical school believe that they have to have done this in order to get in, right? And now the medical schools are starting to say, actually, that's not a qualification, but some of them still do. And the residency programs still, in many cases, will say, oh, you went abroad for 2 weeks. How cool, right? So this is something that I think is starting to change, but it's kind of slow and changing. And this is a current video. This is online right now. Okay, so in this debate over the pros and cons, there's certainly many arguments for it, and you know these arguments. People get to be altruistic, they can bring supplies where it's needed and services, that it's valuable for people from privileged backgrounds to be exposed to other cultures, to poverty, and it brings in money as well. And so it's good for the volunteers in many ways. It can be good for the volunteers. I don't always think it's good for volunteers if they come back with reinforced prejudices. You know, all Africa is poor and they just need us to help them. That's not actually true. So those are some of the arguments for. The arguments against is this practicing without training, without licensing. This is more controversial, that health professionals who go into other countries most often do not have licensing to practice in those countries. And I have a colleague who's the director of global medicine from University of Minnesota, and when he talks about this, he says, I am licensed in 2 countries and in 5 states in the US. I live in, because he's worked in different places in the US, he said, I work in Minnesota and I live 30 miles from Wisconsin. If I go into Wisconsin and practice medicine, it is illegal. I don't have licensing in Wisconsin. So the whole issue of practicing in other countries without licensing is an important one. Some people would say because it fosters dependency. That's, I think, a debatable but important issue. Undermining local professionals. Oftentimes, people who go on these trips, and none of you here, but I'm talking about the world out there that you are a part of, that we're all a part of, the assumption that there are no local doctors. So I love, you know, your comment that you learned everything you knew from the local doctors. Many volunteers just assume there are no local doctors, and they go in and provide services for free and undermine the doctors who are making a living from seeing patients. That's a problem. And then all the time and money. The picture I have here, if you do a Google image search for equipment graveyard, this is one of many, many pictures of places around the low-income countries where people have gotten fabulous equipment and they just can't use it, don't have the facilities, can't repair it, and it ends up taking up a lot of space. And then the harmful services. There are cases of harm by people who don't know what they're doing, or who do really good work, but then they leave and the follow-up is not there, and so forth. So anyway, so these are kind of the general arguments that you read about, but as a sociologist and a researcher, my question was, okay, what do we actually have in the way of evidence for any of this, right? And the reality is there's very little. When I interviewed people who run programs, and I said, so how do you know if you're making a difference? The first reaction in many cases was, that's a good question. Hadn't thought about it. Yeah, I guess we should evaluate it. But we know we're making a difference. We know that people are happy, they ask us to come back, they smile, they thank us. We've seen hundreds and hundreds of patients. You know, we see people who couldn't walk, now walk, and people who couldn't see, now see. You know, it's obvious that we're helping. And of course, those are important pieces of evidence. But there's actually very little effort to evaluate, as we heard about before. The problem of evidence is a big one. And there's very little attention to host communities, and that was mentioned also. So I started with these questions. You know, what do people in the host countries actually think, right? Since the literature is all coming from people like us in the North, global North, how do their preferences correspond to what people actually do? And are there ways to improve these short-term trips? So that's the book that Christina mentioned. I did a lot of interviews, I did a lot of surveys, I did a lot of reading, I participated in a couple of programs. And results. And I'll try to do this quickly so I give Jill time to talk about her work. When I asked people in, host staff who work with volunteers. Okay, so first of all, keep in mind, methodologically, that's a really poor approach. I come in as a visitor, a North American white woman, and I say, so, what do you think about these foreigners coming in, right? Nobody's going to say, we hate you. Nobody's going to say, well, it's nice that you bring us money, but otherwise, right? I was able to, even so, get some interesting answers. The best results were from a former student of mine who's Ghanaian, who did research, who asked the same questions in Ghana and got very different answers. So my current project is actually, I got some funding to hire social scientists in 3 countries that host volunteers, and they're doing the project. They're doing the research, they're designing it, they're going to present it at conferences, and it hopefully will provide us with a lot richer. So, but what I learned anyway from that imperfect was that people liked the extra hands, the energy, the equipment, when there was capacity building, liked it a lot. And they also liked, people brought money and they bought stuff, and they also felt a certain sense of solidarity, like somebody cares about us. And some good social connections. What were the harms that they saw? For some, it was like, oh, I can't get home because I got to take these volunteers around and meet their needs, and is this program going to last? Will I have a job? The competition I mentioned, and just sort of it's a waste of time. It's nice, but really doesn't make much difference. The thing that came through most clearly as a big issue for some people, and they said this is an exception, but nevertheless, the thing that bothered people the most was the disrespect, right? And there are now studies that have looked at this issue, and I may get to, but that also say that. Interviews with host staff are most bothered by the arrogance of outsiders who come in and think they know better, and have no concept that actually people who work in that field and have been working there actually do know a lot and have experience. And anyway, so this is sort of the conclusion of that research when I asked organizers about their common practices, and then I asked host staff what they would like. What I found was that the dominant practices are 1 to 2 weeks. The host staff said at least 3. But they recognized that some highly specialized surgical interventions were helpful even for a shorter time. Most applicants are accepted, very minimal screening. The host staff wanted people to be prepared and to be, to have certain characteristics. Very little preparation. Partnership, I found that half of the organizations I surveyed did not have regular partners in the host country. And when they did, it was mostly to help set up the logistics of travel and housing. They didn't have real partners. The host folks wanted to be at least half in charge of what was going to happen. It's unusual. Again, difference between the most common practices are direct provision of care, whereas the desires for more capacity building, and then needs assessment, it's just rarely done. So out of that book, I came up with a list of 9 best practices. That was mine. And then, of course, when it came out, I saw that there are a lot of people who've written best practices and guidelines. And so my next project was to analyze 27 published sets of guidelines from many different sectors: religious, NGO, medical associations and so forth. And there's a lot of consensus. And Manish talked yesterday about people working in silos. One of my goals is to try to say, okay, people are doing similar things. And what I did was to look at these 27 along with a group of colleagues and also look at literature on what host staff thought. And again, we found consensus, but no enforcement mechanisms. None of those 27 were written by or led by host country professionals or organizations. Many countries do have regulations, but they're mostly ignored. That's the paper, if anybody's interested. And as I said, after it was published, I saw your guidelines, and there are more that have come. So that's the ACAIM one. So out of this, we came up with 6 basic principles that were common through most of the guidelines, not all of them, but that were most frequent. First, the host partner that defines the program and is involved all the way through, involved in directing and teaching the volunteers, not just helping get the food and interpreters. Sustainability, that's something that is key and is mentioned in many of the guidelines. Respecting local governance and ethical standards. The mutuality of learning, this was added not from the guidelines, but from the literature on what host staff want. Respect. Appropriate recruitment, supervision, and so forth, and evaluation. So these 6 principles emerged from that analysis. And then we asked, well, why aren't most of the programs doing all of these things, even though people seem to agree on them? So first of all, there's no oversight, there's no regulation. Anybody can start a program and just do it, right? In this country, you want to start a program, you can get some people, some money, some volunteers, find somebody in another country who says, sure, come on, we've got sick people here, and you just go. There's no limitation on what can be done or on the quality. It's a very difficult thing to do. It's also really expensive and difficult to do a good program, right? To do all those 6 things, to develop a partnership that's a real legitimate mutual partnership takes a long time, and it takes money. Evaluation is really difficult, takes time, takes money. No surprise that folks who are involved in doing these programs respond to the demand. They create programs that are sometimes good, but they're focused on, can we get them there? Can we get them back? One woman I interviewed is a nun who's done a lot of trips to Haiti. She said, my definition of a successful program is one where I don't have any disasters. Everybody comes home safe. Nobody died. That was a good trip. Yeah, that's important. That's got to be important. So lack of enforcement in the host countries, and then also the feeling like, why do we need to bother? We know we're doing good work, so it's good enough. So, as I said, there are many groups that are trying very hard and doing great work trying to address these problems, looking at the issue of how do you enforce guidelines, how do you get a better sense of what the host communities want, how do we evaluate? We have somebody in the audience who's working on an evaluation, Dr. Boni, and others as well that are doing that. And I'm hoping we'll see more of that. But I will stop right there and let Jill Rothman take over because she's been doing some terrific work at Einstein and has some really good lessons from that work. Yes, do you have a question?
middle LMIC. I think many of them have caught on to what the needs are. I think the lowest of the economically strapped countries haven't caught on to that.
I agree with you, but I think some of them are. There are now countries, you know, you may know Kenya stopped all foreign doctors for a short while. India has imposed some limits and regulations. There's more of that now as their own capacity increases. One of the most interesting interviews I had with somebody who goes on trips, when we talked about partnerships, she said the best partner is the one who can say to you, actually, no, we don't need that, right? And I was in Ghana not long ago and was talking with a Ghanaian man who runs a training institute, and they have the possibility of getting a lot of money from an American corporation to develop further training. And he basically said, no, not the way you're thinking about it. What we need is this, and until we can get to this, we're not going to do it. So turning down money is tough. But I think having that happen enriches partnerships tremendously and makes these trips so much more worthwhile. Thank you for that. I think we're seeing more of that in some of the lower income countries, less in others. And we have to think about, what if it was us? What if it was other people coming here, right? Okay, enough. Jill? Okay. This forwards it. Okay. Okay, so this just clip on you. Okay. Okay, thanks. Oops. We are Siamese twins. All right.
Oh boy, I'm afraid to let go of anything.
I know.
You know, let me bring this with me. I'll give it back to you. Okay. Okay. Hi, everybody. I'm Jill Rothman. I run the Global Health Fellowship Program at the Albert Einstein College of Medicine. And so as somebody who sends students out into the world, I'm very, very interested and involved with all that Judy has just been talking about. And you know, as we have more and more students, at least at Einstein, I think throughout the country, interested in global health, interested in going out into the world, and with this lack of an overseeing organization, the responsibility really falls on each program to make sure that we are having ethical, sustainable, collaborative programs, and that we're guiding our students in the right way. So, so all this important information that we've just heard from Judy, what does this mean to somebody in my position, somebody who is sending these students? How do I put these ideas into actions and into a program that is something that we can be proud of? So I have the responsibility of trying to have a safe and a valuable experience for my students while keeping in mind how to keep it ethically sound, all without having this overseeing committee that would really be able to help keep track of programs. On the one hand, we feel that this is a really important experience, especially for aspiring physicians, but we need to balance that against the possible negatives, all these things that you just heard from Judy, things that could happen. In our program, we've tried over the past few years to adapt what we do to make sure that we're minimizing the negatives and maximizing the positives in what is an evolving program. Each year, as we learn more and more and get more feedback, things change. But there are a few things that we are certain of. First of all, we really do think it's important for medical students, whether they intend to pursue global health or not, to have a certain amount of cultural competence or cultural humility, particularly in a place such as New York with such a diverse population. Participating in a global health experience can help by exposing them to other cultures and other healthcare systems. Second, students must obey this. You cannot do there what you cannot do here. This is sacred and non-negotiable. The next thing is that programs are better if they're ethical, sustainable, and true collaborations between partners, with the corresponding notion that we, hosts and guests, are eager to learn from each other. So a little bit about my program at Einstein. It's one of the longest running programs in the country. It was started by Dr. Albert Cooperman. I don't know if anybody's heard of him. He's kind of like a giant name in the field in the 80s. And I guess this is similar to other programs for med students. There are a few opportunities when students can participate. The summer after they finish their first year, and we require them to stay for a minimum of 4 weeks. They can do an elective in their 4th year, and they need to stay for a minimum of 8 weeks. Or, and this is becoming more and more popular, to do a certain amount of time in between their 3rd and 4th years. A lot of them are taking the year and doing something, and I see they're really changed when they come back. It's a great experience. There are 3 categories of programs that our students participate in. There are med Spanish programs. I mean, do most of you deal with med students doing global health? Like, okay, good. So you know there are med Spanish programs. Those are usually students who want to have an immersive Spanish experience where they really become more proficient in the language, and also they also get to shadow in clinics and things like that. Then there are programs that are not Einstein programs. They're outside programs like CFHI or Himalayan Health. This is where the organizations are really in charge of these programs, and we just send the students off. We are constantly vetting these programs. A little bit more about that in a little while. And then we have programs that are led by Einstein faculty. Those are ones where faculty who have long-standing relationships with programs bring students with them in different types of either research or educational programs. Depends what they're doing. So our primary, because we believe so deeply in how important this is, we really try to take away barriers that might exist for students to travel. Most of them are financial, so we actually pay for most of the fellowship. The cost of the program, the travel, the cost of the program, we pay for most of it. We also arrange for a travel clinic to take care of all their vaccines and prescriptions, and what insurance does not pay for, we pay for. And that's, you'd be surprised at what insurance does not cover in terms of vaccines. A primary goal when we send students out is, first of all, make sure everybody's safe. But second of all, the quality of the program. It needs to be something they're really going to learn from, and while fulfilling these conditions of ethical, sustainable, and collaborative programs. So some of the things that we do to make sure of this, there are the basic things, like we need to have them sign and fill out the basic documents, like make sure they have, you have all their emergency contacts. We have a very thorough application process where each student comes and meets with me, and I listen to what their experience is, I listen to what their interest is. I try my best to match them up with the right program or the right faculty member. We also have them sign a code of conduct so that they realize all the things that we've been talking about. They're signing and committing to certain types of behavior. We also have pre-travel lectures that are required. Every student who's traveling must attend these lectures, where we talk about things like safety, health, the ethics of traveling abroad. We have interactive cultural competence exercises. We have tips from students who have actually traveled before. We even talk about photography and what's appropriate when you're carrying a camera around. You can't just snap anything you want. We've just included a module on research for students who are going to be participating in some kind of a research project. Research methods, what you need to know about IRB. We talk about how to navigate uncomfortable situations. These topics evolve. As students come back and as I get feedback and I see the need for new topics, we include them. I'll give you an example. A couple of years ago, some students came back from being in a hospital in rural Uganda. And they emailed me while they were there. They were very upset because they had heard some staff members making homophobic remarks. They wanted to go to the director of the hospital and complain. So I said, no, don't do that. Number one, it's illegal. To be homosexual in Uganda is illegal. You are guests of the country. It is not your place to do that. But when you come back, we'll talk about it. And when they did, we did. We had a session. I brought some people in. We just talked all about the situation. And we talked about how best that they could have handled it. And now, because I saw the need for it, that's one of the modules in our pre-Treble lectures, how to handle these situations that are offensive, but that we really can't do anything about. When the students travel, we have a midsummer check-in. Every student must check in with me so I know they're okay. And they know that if they don't, I'm going to find them and get after them. We have a contract with International SOS, and every student is required to register. We have ongoing monitoring of overseas activities with International SOS and some other organizations. With International SOS, we also have something that's a mobile check-in feature. So on their phones, if they have the app, they just push on a pin, and it shows up on my map exactly their location, which is good. I also have something, when they come back, I have them take a post-travel survey where I get a feel for how the program went. I have a few questions I ask. And I have them write some reflections. I give them a template where I ask, these are some of the questions that I want them to think about and to write about. And I have to say, they've told me that, this exercise really brings back to them what they went through during this experience, reminds them of how important it was. Here's some more questions. Oh, here are some excerpts. I mean, I have hundreds of these writings. I picked out a couple of excerpts to show you because I think they show how important this experience is. So I grew up surrounded by people that speak English, so it was quite a shock when I couldn't understand what anybody was saying. It never dawned on me how scary it is when people cannot understand you, especially when you're sick and in need of help. This experience definitely alerted me to how some patients must feel, and I'll keep this in mind. The most important thing I learned was to be open to new things. If you're open to other people's lives and lifestyles, you can at least understand a little bit of what people are going through. It was interesting to see these differences because it made me aware that as a physician, you need to consider environmental, cultural, and habitual differences when treating patients. And while it was hard for me to accept her opinion, I realized that responsible global health work begins with listening to and considering the opinions of those most affected by such work. In that moment, I took on the role of a student with my Haitian colleague as my teacher. This served as the backdrop for the rest of the course. I realized that to do global health work, to practice social medicine, and to strive for social justice, partnership is paramount. And I'm so proud of these students for these realizations. The other thing that I do, and I have to say this is probably for me the most important thing that I do, is when the students return, each student is required to come and sit with me and have an interview, an individual interview with me. And I have a list of questions. I have some of these questions listed here. From this interview, I learned so much about the experience. I learn things that I feel should be changed, things that maybe are okay. I get a feel for what students have gotten out of this experience. And what I do also is that if I hear something that does not sound right to me, I go to that program. Now, if it's a faculty member at Einstein, that's fine. I mean, that's easy. But I can tell you, I always go back to the non-Einstein programs. And if there's something that I think was wrong, I will ask them to change it. I'll ask them to explain why they did it. And if they will not, then I will not send students there anymore. And I've had a number of times where I've called these programs. Most of them are very open to thinking about it, changing things. But it's really important to reach out to these programs. There's no organization that's overseeing this. It's up to us. We have to make sure our students are having a good experience. And if they're not, and if something wrong is happening, we are the ones who need to reach out. So based on my interviews and all this feedback and everything that I'm getting, I really feel like the most desirable program, or the most valuable program for the students, is the one where they go with an Einstein faculty person. I think when they do that, there's more accountability. You know that they're going to be responding to the student. There's definitely more sustainability because the student's going to be hooked in with the faculty member's project. There are many more long-term opportunities for the student. If it's something they're interested in, they could be doing this for 4 years with this faculty member. So what I've been trying to do with our program is I've been trying to shift it so that we are developing a lot more faculty-led programs. And I really see a difference in the response of the students. They're so excited about these programs. They're coming back and they're really having great experiences. And I'll just tell you about 2 of them that I've developed over the past, well, one of them I've developed over the past few years. One of them I actually just returned from last week. So we have a partnership with a university in Chile. And what we've tried to do is have a sustainable multi-level project going on there, making it more into a program site rather than an isolated project that students are working on. What we've done is we've collaborated with faculty and students there, asking what issues are important, like what's important in their community. And after a lot of discussions, we came up with a topic. I've had students going there, working very closely with the faculty there. We have students from there coming to us at Einstein. And we're actually, what they do is each year, the incoming students build upon what was found in the previous year. And we're in our 4th iteration of this project right now. It has to do with adolescent reproductive health. And it's going really well. The students are really excited about it. People in Chile are really excited about it. And we actually just began another program in Chile in environmental health based on how well this has gone. Again, collaborating with faculty and students there, having it be multi-level with faculty, students, different, 4th years, 1st years, and we're really proud of it. The other program that I actually have just returned from was in Kenya. Over the years, as I've worked more and more with these students, I realized that for students who are 1st-year students, they can't do anything. And they're not allowed to do anything. So for them to try to kind of work in a clinic, I don't really, I mean, it's interesting, but to me, and based on all the reflections and the feedback that I've gotten from them over the years, I think the most important thing that we can do for them is to introduce them to the different cultural concepts of health, and how important that is, how important it is for a physician to recognize that you cannot discount that you have to listen, that you can't say, oh, that's silly. You have to acknowledge that. So what I did was I put together a program where I had 9 Einstein Med students, and I had them mentor some high school students in the Bronx for a few months before we left. I won't go into the whole, if anybody's interested, I'll tell you more. I'm not going to do the whole thing right now, but we incorporated some art into that also for even deeper learning. So I had my med students, I'll call them the mentors. They mentored these Bronx high school students talking about what are the issues that are important to them, talking about health, working on these art projects. And we had a high school in Kenya that we were also working with. And the Bronx kids and the Kenya kids were Skyping with each other, so learning about each other also. Then I brought these 9 mentors with me to Kenya. And they did the same thing in a Kenyan high school. They mentored these Kenyan kids, and we actually have just returned. And I'm so happy with how it went. I didn't know how it would go, and just from seeing how it went and the feedback that I've gotten so far, they really got what I wanted them to out of this. And the plan is that now, based on all the things that we brought back from Kenya, you know, we've had evaluations all along the way from both sets. We've had artwork, we've had, you know, they produced books and videos, the mentors helping them to talk about issues important to them. They did this artwork. We have them make masks and then design masks to express things, and I mean, a whole bunch of stuff. We're going to take all of this and put it together and present it to our next class in the Bronx. And it will be a cycle that will just keep repeating. And I'm very excited about this. So I think, you know, we have a lot of other programs that I'm excited about also. Where it's Einstein-led programs in Rwanda, Vietnam, a few in Uganda. Let's see where else. I have students in Dominican Republic, in China, in Ecuador, and all of them are going with these same thoughts about knowing that you have to have an ethical program, that you have to have this attitude of we are learning from each other. I'm here to learn about this culture. I'm here to observe other healthcare systems, and I want to know what can I learn from you that I can bring back. I think my time is up.
Yes, we have a couple more minutes.
Oh, do
questions or?
Yeah, here.
Questions or comments? Any questions?
Do you require your students to have travel insurance when they go abroad, or is it?
We require that they be registered with International SOS, which is evacuation insurance. In terms of other insurance, it's up to them.
I agree with 99.99%, but I work with someone who actually does, I don't know if you call it a parachute mission. They go into the Caribbean and they do 100+ flips on kids in like 2 or 3 weeks. And they actually train people how to take care of post-op, and they come back once or twice a year and do more. I guess in some perspective, that's probably something that can be done pretty safely to achieve a kid's life. So that's one program where I think differs. I don't know how y'all feel about it.
No, I agree with you. I think there are exceptions. I think something like that is an exception, you know.
Yeah, but even within that, there's a great mission that's like the parachute surgical missions. There's a Operation Smile, so monitor evaluation, long-term outcomes, and sort of infrastructure development where they're doing operations. And they're sort of the paradigm of having to do those things first. A lot of these come in and they do orthopedic, you know, they drop in orthopedic missions, and those are great, but you know, you need to have some follow-up and some infrastructure stuff when you're doing. But Operation Smile really is something that stands out for that.
Say there's critical mass where group to form to actually provide some level of not necessarily credentialing, or maybe eventually lead to credentialing, but maybe start doing, you know, at least synchronization. of programs.
You would like a way for people to know whether a program is good or not? Is that what you're saying?
Or does it, well...
This has been occupying my thoughts for a couple of years, looking for a good housekeeping seal of approval.
So the problem so far has been that everybody's doing this stuff on their own.
Right.
And no one's really talking, or recently talking to each other. And, you know, it takes collaborative effort to do this kind of thing on a national scale.
We actually talk about, well, no, you talk about what we tried to do at our last conference. We really have been trying.
No, I think there's a lot of efforts to do that. The Einstein conferences have done this. There's a group out of Minnesota that had an Ethics of Health conference. I mean, people are talking about it, but still trying to bridge that. I've been working with a group, we call it the Coalition for Responsible Short-Term Experiences in Global Health, and it brings together people from evangelical mission doctors to corporate social responsibility people and NGOs and universities, trying to advocate for and work towards better, more responsible. But yeah, there's a lot to be done, and yeah.
So this is a laser pointer also if you want to use this one. Okay, I don't need that then. Forward, backward. And where's the laser? Right here. Forward, back, okay. But just make sure your fingers below here. Okay, gotcha.
And no longer really
Where's
has
the-
the need
where's
for
the
this
top?
kind of work. So but I'm
once
very
you're done,
sensitive to this idea of colonialism.
You can put
and
mine up
so
now.
forth. The thing I wanted to mention actually is that we are not really alone in doing, we in healthcare are not alone in doing the kind of work that we're doing. There are other organizations in other sectors that have done this and have actually faced the problem, the ethical dilemmas, and are having the and have had the conversations that we're having today. So I think one thing that we really need to do is take a look at how they have
I'll make sure I'm done. I'll fly
those
through some
issues
stuff.
and have answered those
15.
questions as to.
You're absolutely right. Health is just one piece of a much larger international volunteering. People
mine's the
do
first one.
conservation, they do education. The other sectors have not, I think, solved these issues. Some of them are talking about it. One of the biggest changes that I've seen is organizing around stopping orphanage tourism.
The name of mine is ACAN 2008.
Orphanage tourism is probably one of the biggest components, and many of the groups, particularly church groups, but others who go and do clinics for a week also do orphanage visits. And there are now international organizations that have come together to say, not only is this not good for kids to have people come and go, the opportunities for exploitation are huge. The opportunities for pedophiles to take advantage. I mean, there's just, so this conversation, you're absolutely right, is taking place in a variety of sectors.
I think the other thing, I'm sorry, I think the other thing is that we're healthcare providers for the most part. We deal directly with human life, so we have the highest standards of ethics, or we should adhere to the highest standards of ethics for that reason.
Oh. I'm sorry, I just wanted to add about what we were talking about surgical missions and disaster response, for example, is one of the issues that I'm more concerned about, disaster response. I did my residency in Puerto Rico during the hurricane, and I was part of that response and working there and receiving the help. It causes a lot of major ethical issues. For example, the boat that came in, they did a lot of procedures and surgeries, and then they left. No follow-up for these patients, say that nowhere to go. They caused a lot of they had infections, they had a lot of complications, and a lot of hospitals would not take them because they weren't the ones that performed the surgeries or did the procedures, and the patients had all these complications. So it caused a lot of ethical issues. So it's something that it's a concern in disaster response going forward in the future.
Is incomplete care worse than no care? You know, so if you help 90 patients and 10 of them get worse, I don't think there's an answer to that question. Absolutely. Yeah, so Elon Musk would have been better sending money and not... not that summary thing. But no, this is a big problem. And there are surgical missions that you describe that do really a great job of not just doing surgeries, but training local surgeons to do that surgery and being there for the follow-up. Doing surgery without opportunity for follow-up and complications, you know better than I, it can certainly be problematic.
I just wanted to plug one of our now chiefs in our ultrasound department. They went to China, and part of their program was just education with ultrasound, and that they thought they could teach a core group of people. I think that's been a lot of what everyone's been saying. If you could find people that you can educate who can then continue to pass that and spread that information, that would be the best thing, which I think would have been a best plan for a lot of the disaster responses that we see. If you could find the small group of people, educate those people who can then disseminate, it would be the best.
And let me just add to that. Do they have the equipment and the environment in which they can do that, right? So I participated in a training session for lab technicians in Haiti, and they loved it. They learned a lot. And then when we asked, can you actually apply this in your own lab? Well, actually, something like 60% said, not really. So, yeah, appropriateness is also part of the story. But these are all, we could go on and on and on. Thank you for the really great comments.
I want to thank our speakers, Judith Lasker and Joe Rothman, for inspiring a very animated discussion that I think could go on for a very long time, and I think we should continue the conversation as the conference continues. I'd like to please thank you with these certificates and hope that you will ask the ladies more questions as we go along. Thank you. We'll move on to the next session.
So we'll start right into my next talk here, the next segment of the hour. So much of what you folks discussed is exactly what needs to be discussed, has been discussed in the past. I'm going to fly through some of my slides because I would much rather have a question and answer than a death by PowerPoint, presentation, right? So this is me. Just the bottom is what I'm going to mention some nonprofit organizations. I have no financial affiliation with anyone anywhere. So places that I mention, I don't have any financial connection with them at all. I simply mention them because they help solve problems that I had, and so I just want to pass that on. We all know the need. I'm going to fly through this. This is the Lancet article, the Global Health Consortium. I focus on the surgery things here, but almost everyone in this room are intimately aware with these findings. The key here is that increasing the health care, what is available, access to that health care is critical to the development of the low and middle income country. So they can't get better without improved health care. That's the bottom line. And they need help. This is a textbook that I found really helpful for reference. And it goes into a lot of different ways that these low and middle income countries can actually attack this problem. The community health worker, if you can't get the people from the village, I go to a place in Cameroon, so if you can't get them to the hospital, then you take a healthcare worker and you get them into the village. So the prenatal health care is done by going out into the village, not trying to get the pregnant patient to you. Physical exams, well baby checks, immunizations, they're done in the village because you can't get them for a lot of different reasons into the clinics or to the hospitals. Task shifting is interesting. It's taking a midwife and teaching them how to do a C-section, right? It's taking a nurse, teaching them how to do an epidural or a spinal so that you can do the C-section. Now you still need the surgical ward, the surgical theater, but task shifting is another way that I've seen low and middle income countries attack this problem. You can read this for yourself. There's a lot of inexpensive solutions to what we spend a lot of money on here in the United States. This is just a very small list, but good care does not have to be expensive. We have forgotten that, and that's one thing I've learned over and over again through my trips. All right, we've talked about parachute missions. You know, there's all kinds of different terms. There's drive-by volunteerism, or humanitarian volunteerism, or whatever you want to call it. It's you swoop in for 2, 3, or 4 weeks. You do a lot of good, hopefully good, for the people that you take care of. And when you leave, everything goes back to exactly the way it was. Right? There's no sustained improvements in care whatsoever. The only thing you have done is you might have helped the people that you took care of for that month. Nothing else changed. So I'm a former military guy, and so when I retired from the military, I wanted to start an international program, and I wanted the sustained improvements in care. And I didn't care if I took a resident, I didn't care if I took a medical student. I had no money to do it, but this is what I thought. I wanted sustained improvements in care, and then I wanted to be part of training the next generation in the host nation to carry that on. So that was, you know, a pie in the sky type thing. But this stands for the St. Luke's International Surgical Studies Program. It's what I started. I don't want this to be a show and tell. I want this to just be a topic for discussion. But this is how we attacked it. We said, okay, we need supplies, fill supply needs, equipment, training, and then partner. And that's the key, as you mentioned, as was mentioned the previous hour, is that you're not going to show up, or if you do, you get nowhere. If you show up and say, I'm from the West and I'm here to solve all your problems, you might get a courteous response. When you leave, you'll never get invited back. So the way I started this program is I partnered with this one hospital, and right now it's just one hospital. We go there 2 to 3 times a year for the express purpose of building that relationship, because you know, even that first trip, I had to basically show up and said, tell me how I can help. If you show up with, I'm going to fix all your problems, it's arrogance, and they can pick that up, and you know, they don't want anything to do with you, to tell you the truth. And there's plenty of instances that's already been mentioned about that. So it's a faith-based hospital. Why? Because they treat everyone that comes to them regardless of money. They have no connection with the government. So they don't need funds, and therefore they're not beholden to the government. And as already mentioned, the lion's share of the work is being done by faith-based organizations, period. That's just the way it is. They accept anyone, no matter what your personal statement of religion is. Anyone can volunteer there. They have a rigorous process, but the bottom line is it is a tertiary referral hospital in Cameroon. So if they don't take care of it, it just doesn't get taken care of. If they say, sorry, we can't help you, they go back to the village and they expire from whatever illness or injury they have. So they're very busy, high acuity, and that's something I was looking for. And I'll get to in a minute some, you don't have enough time to go into how we selected them, but the bottom line is they have 20 residents, which was key. This is that, teaching the next generation of healthcare professionals to take better care of the population that they serve. So there's internal medicine, there's surgery residents there, and I'll get more into that in just a minute. So it's a pleasure to go and actually take part in their education. This is the hospital, humongous, just from a surgical standpoint, much busier than the hospital, University Health Network in Bethlehem that's my parent hospital, much busier. And they need help. They're used to volunteers. So when they have 100 volunteers a year, the ground transportation, the housing, the food, it's all streamlined. They're used to having visitors, which is another real benefit. So mountains of Cameroon, it's great, but again, I don't want this to be a show and tell. So this was my pie in the sky. This is how we're going to help sustain improvements in care. So let's tackle each one of these. Supplies. I found out that my University Health Network, where I have 10 hospitals now, supplies that we no longer stock, expired supplies, although I never take expired medications, but we all know that expired sterile gauze is still good. Titanium staplers. It boggles my mind why that has an expiration date on it. The only part that stays with the patient is the titanium staple, and that comes out in 10 to 14 days, right? Why we throw those things out in the United States is aggravating. But, so, we have this room, and this room is in our distribution center. They put all these supplies, pallets and pallets of supplies, and I go through them, right? A third is just junk to them. They just can't use it. It might be $50,000, $100,000 worth of expired wires and aortic grafts and balloons and all kinds of stuff, but if they can't use it, it's just junk and it's a waste of time. So I get the residents and the medical students that go with me. We go there about a couple times a month. We go through all these boxes and we pack them up. So what do you do with these, right? That's the big question. You can't just pay to have them shipped to Cameroon. It costs way too much money, much more than what's available, what contained in the boxes, right? So, you know, I didn't know how to tackle this. Maybe some of you, what I started with is I went to my partner facility in Cameroon and I said, okay, Bingo Baptist Hospital, how do you get supplies from the United States? And they said, well, it's simple. It's the North American Baptist Organization. They send us a container about every 6 to 8 months. They don't know where the supplies come from, but when they fill a container, they send it. I said, beautiful. So I called them, and they said, absolutely. You send these boxes right here from Pennsylvania. They're housed, centered in Texas, and just get the boxes to us, and they, for free. They put them on the container that's already paid for, right? So my cost in getting each one of these boxes is what it cost me to FedEx it to Texas, $20 to $25. That's my total cost per box. So to date, the program's been going on about 4 years. We have sent hundreds of boxes this way, hundreds of thousands of dollars worth of supplies that were useless and worthless to us here in the United States, but is gold to them. So we can also take them, of course, was mentioned, this is me, my suitcase. Every time I go, I take a suitcase of supplies and go through it with them. But the lion's share of the supplies are gotten there by a nonprofit organization with whom I have no contact, no financial interest, other than I send them boxes. And that was a great way that I solved this problem. Equipment. So I have laparoscopic towers, endoscopy towers. This is a portable ventilator. Their ICU, as many of you I'm sure have experienced, they had no ventilators. So the family members were literally bagging the patients, and that's how a ventilated patient was taken care of in their ICU. So these I took 4 portable ventilators. They were just routinely being cycled out at Good Shepherd Rehab in Pennsylvania. They were just going to throw them out. And my Navy connections through a Navy flight nurse and et cetera, he said, do you want them? I said, absolutely. So we took them, we trained them, as the next slide is going to show, and to this day, this is the first ever ventilated patient in the hospital. But to this day, whether I'm there or not, or whether my team is there or not, the ventilators are there being used. Now that's sustained improvements in care, right? And it's through a ventilator that was in the United States, we were just going to throw in the garbage. It's absolutely worthless to us. Perfectly functional, and they're first. So now they have 4 ventilators in the ICU. These were so small, I just put these in my suitcase and carried them. Now, bigger equipment, I mentioned this one organization here. I have no financial ties. It just so happens that they ship equipment to this hospital. Every 6 to 8 months, they fill up a container, hospital beds, other large equipment. And lo and behold, they're out of Pittsburgh, Pennsylvania. So they come and they pick up these things right from my distribution center. So my cost in getting these pieces of equipment plus bovies and suction machines is 0 cost to me, 0. They come pick it up and they put it in their container and they send it. So any partner facilities you folks are thinking about and you're overwhelmed with the supply or the equipment, how to get stuff there, start with them, because undoubtedly they already have a supply chain that you can tap into for very little or almost no cost whatsoever. So this is the biggest piece right here. We took one of our old ambulances, we rebranded it. Again, these were just going to be scrap to us. How do you get an ambulance there? It's way too big, right? It doesn't fit in a container. I went to my development office. We have a lot of donors to the hospital. Lo and behold, one of the companies is known for shipping construction equipment internationally. So my cost to ship that ambulance from Pennsylvania to Cameroon was $5,000. Right? This is the first ambulance that the hospital has ever had. So that, again, is another sustained improvements in care that we as an organization at ACAM and you owning your own little international medical programs, that's what we need to aim for. We need to aim for not just a 1-month trip, but we need to aim for sustained improvements in care and supplies, equipment, and then visiting medical professionals. And this is why we mentioned it earlier, several different speakers mentioned it. You have to partner with the facility and you have to repeatedly go there. That's how they get to know you, that's how you get to know them. And just giving them, say, ventilators, right, without teaching the residents is a waste of time, right? It's just a big paperweight. That's all it is. So one of my partners taught the residents on a separate chip. I'm giving a talk on basic ventilator management. These are 2 ICU nurses in the ventilator. So it takes repeated trips and repeatedly teaching the same thing because you have employee turnover, right? New nurses come in, new residents come in. So you have to partner with that facility, and your efforts to improve and to effect sustained improvements in care is ongoing. It's never ended. Finally, I'm a general surgeon, but we also have an OBGYN, an orthopedic surgeon, as well as residents from OBGYN and general surgery that go with us on each trip. But it was never my intention that the program would grow. But healthcare workers, our colleagues in our hospitals, sometimes all they need is just to know that the program started. And it's amazing who just says, hey, you got the program, I want to be part of it. And so we have an OBGYN and an orthopedic surgeon now that goes at least once a month. Partnering with a facility that has a residency program is critical, in my opinion. Again, I have no financial connection. PAC stands for Pan-African Academy of Christian Surgeons. They run 9 different general surgery residency programs throughout Africa. They were at our last meeting last year. It's a great organization, but what I like is, if you're thinking about sustained improvements in care, I go and I get to operate, this is Kasumba Moses. He just graduated. Yeah, he just graduated this year. He's off in Uganda as a general surgeon. So my investment into him is a future generation. One of my residents operating with an intern general surgery African counterpart is a fantastic learning experience, and that's a whole nother talk. But what we need to do is we need to aim, as we all know, for sustained improvements in care. Again, I'm never done, but in about 4 years, I've been able, through a lot of help, making a lot of mistakes, but very inexpensively, actually affect sustained improvements in care at one hospital in Cameroon. There's a lot of partners in that. Again, I'm just one person that visits there. But if you're feeling disheartened at all, you don't know, you don't have a lot of money, it can be done cheaply, and it can be done effectively. So I'm going to stop there. Any questions? Because I really like the question and answer time after the last.
In as far as sustainability, one of the things that we forget is that very often, rather than bring out technical expertise in actual hands-on patient healthcare, organizational changes and improvements are no less important very often. So starting programs that were not there, changing attitudes in the country, affecting even the political climate that sometimes stifles progress of the healthcare community is no less important and very sustainable in the end. Even if you only come once or twice, as a foreigner, you often have an impact that is disproportionate to the one that you can have just treating patients.
They have to get to know you, and yeah. While we're changing mics, any other questions? Sure. Right. Hold on to the question.
Forward, reverse, laser. Do I use the mic? Yeah, that one's going to come to the system. That one's going to go online.
All right. Good afternoon, everybody. So what we are going to talk about is the INDUSEM mission, which we started about 15 years ago to transform academic emergency medicine in India. India has about 1.5 billion people who live, and there was a lot of need for developing academic emergency medicine. There was no department of academic emergency medicine. There was no emergency training in the curriculum. There was something called as casualties which existed, and that's when we started that. I am a faculty at the University of Florida at Jacksonville, and I specialize in international medicine with my focus in academic emergency medicine. My objectives are going to be to talk about the history, to talk about the fundamentals of how we developed this program, identify the salient achievements, and how did we grow and what are the opportunities. International emergency medicine used to be a core fundamental many years ago when I was not in emergency medicine in the United States. The definition of international emergency medicine at that time used to be conferences, rotations, MOUs with various private hospitals in India, funded research, maybe get a grant and do some research, MPH driven agenda that you can go to India, do some HIV work, and that would be part of your MPH, and social work and NGO, which you have been hearing since morning. What's India? India is 125 crore, that's 1.5 billion people, and it's still growing. There are about 35% of our population is youth. English is a known language there, and it's a thing of 3 Ds, that is diversity, development and demand. All 3 exist simultaneously. Education is key in India. You have to be educated. We have the largest numbers of universities, about 410 medical schools across the country in allopathic medicine, and over 5,000 nursing schools. We produce over 60,000 doctors every year and supply it to the whole world. Healthcare is the sector and a market as well. So you have healthcare by the government as well as healthcare in the private. The healthcare provision in India is private and government. So private is self-funded hospitals, corporate hospitals like Columbia, Asia, which exists in India, Mayo Clinic, Collaborate, all these big chains are now coming to India from Malaysia, from Japan, and there you have to pay it out of your pocket or you have insurance. But insurance also pays it only till a limit. After that you still have to pay for everything. And government is publicly funded hospitals. You can walk in, everything is free. They may or may not be attached to a medical college. So there could be government hospital which does not have a medical school, and there could be a government hospital which has a medical school. The education in India is governed by 2 agencies. There's the Medical Council of India, which governs the medical schools as well as postgraduate residencies, and National Board, which only governs postgraduate residencies. So in the government hospitals you need to go to the MCI, in the private hospitals you need NBE to govern your degrees. So what was the challenge in India? There is a lot of gap even today between the number of doctors who graduate as doctors and the postgraduate spots. There's a difference of nearly 20,000 spots in creating specialists and creating doctors. That's a very big gap, because then the aspirations are huge. There's a belief in the community that you are a doctor only if you have a specialty degree. The respect you get if you have a specialty degree is more than what you get as a primary doctor. Biggest example is me. I am a 4th generation physician. Nobody spoke to me in my family. I'm the 37th doctor till I got a specialty degree. They just don't count you as a doctor. And there's a very low thrust on family medicine because there's no degree of family medicine. And things are changing. So what happened from 1999 to 2005? The new field of trauma and emergency medicine was established in India. American Heart established its shop in India. It opens its shop, and the growth of international EM, that is American, UK, Australia, all trying to develop their models across the world. The government of India got interested because they signed the MOU to bring Commonwealth Games to India. And one of the things when you bring such games is that you need to have a infrastructure for trauma and emergency care. Secondly, India went into globalization. BMWs, Audis, everything started coming to India. They wanted bigger roads, faster cars. Of course, accidents, trauma, everything grew. By 2004, Many American, many Australian, UK universities opened their shop in India under the slogan of helping India. And what happened was they started giving out certificates and courses, calling them degrees. And these degrees were not even recognized in their home country from where they were being awarded. So they charged money from students and said, okay, here's a degree, I give you a certificate, you are a specialist, and go figure. Conferences started happening, so they used to come to India, take pictures with ambulances, and they used to show bullock carts of people going on cows and on the street and saying, this is India. And this used to happen in American conferences, and they used to show the poverty of India, this is what India is, which is not the truth. And American Heart courses started being called as degrees. So people used to write ACLS USA, and that used to be called as a degree. And the concept that CPR is emergency medicine. Nothing grew in academic medicine. All this mushroomed, but nobody wanted to work with the government to bring a residency, to train the teachers, to develop a specialty, because that's hard job. It's better to go into a country and start a course and hand out diplomas and say we are helping the country rather than doing the hard work. So academic medicine is patient-centered education, research and care. I joined emergency medicine residency. I was a trained internist in India, and my teacher died on the highway. And when I came back in the night, I saw ER on the television, and that inspired me that I think we need to do this the correct way. So I gave my USMLE and I came here and I joined my residency, and I had this vision that we need to change things the academic way. So in 2004, after I finished my first year of residency, I started INDOCM, the Indo-US Emergency and Trauma Collaborative. And it was a concept where we held the first Congress with All India Institute of Medical Sciences. All India Institute of Medical Sciences is the apex institution of the country where the Prime Minister goes when he's sick. So anything you want to change in India has to change in All India. And if you can change All India, then the India colleges follow. So you have to use a strategy, you change the biggest system, then everybody starts copying and they start replicating it. So the blueprint was drawn where we sat across, like in the United States years ago, people sat across the table and said, well, this is how we are going to develop it. Medical schools were the ideal environment. Any new specialty has to be born in the womb of a medical college. That means it has to have medical students, it has to have a basic science infrastructure, a clinical medicine infrastructure, a public health infrastructure, teachers and postgraduate students. That's how a specialty develops. When you talk about medicine, you talk about diabetes basic science research, you talk about diabetes in public health, and you talk about diabetic patients in the hospital. You have medical students who rotate, you have postgraduate students who practice, and you have teachers who cater to both. You need all that together to make a specialty work. For patient care, anybody can be trained to take care of patients, even mid-levels are being trained today. But when you develop a specialty, when you develop a science, you need to have a 360-degree approach to developing a specialty. So these are the 5 pillars of an academic department in any specialty, that is education, research, healthcare, leadership and public health. So we started an education center called MTech, and we started training teachers and standardized protocols before we launched the request to the government to start the residency. So we got all the deans together, and of course remember, the chief accreditation agency survives because it accredits institutions. If the clients themselves demand for a specialty, they will do it because it's more money for them. So we brought them together, we standardized it, and then we approached the government. So the game changing, we wrote a white paper. The way the white paper works is when you write a white paper, it gets questioned in the parliament because the opposition party will always question the ruling party. What are you doing about this? Nothing is happening. People are saying we need help. So we got this paper into the parliament to be questioned. And that's when the things started moving. So the specialty got recognized in 2009 and opened the doors to all academic institutions to start the specialty. We started the academic college because you remember the teachers come from all the disciplines when you start a specialty: anesthesia, medicine, pulmonology, chest medicine, surgery, orthopedics. Whoever wants to transform into an emergency physician has to leave his parent department, start working in the ER like it happened in the United States. Years later, when a postgraduate residency trained emergency physician comes out, he will not or she will not respect those teachers. It has happened here, it will happen everywhere. We learned that lesson, that there has to be a bridge, that these teachers need identity. So we started a college where we could accredit quality and say, well, even if you have done a residency, you need to be quality in education, quality in patient care, quality in research. We started nursing. We did not leave nursing behind. We realized that 90% of patient care in hospitals is by nurses. Emergency patient care is teamwork. If the nurses are geared towards academics, the physicians will be geared too. So we taught the nurses. In India, stethoscope to nurses is not a reality. We awarded all of them with stethoscopes. You can auscultate, you can do this, you can do vital signs. That changed the culture. Now they felt empowered because they also have a stethoscope. And they started talking, they started understanding EKGs. That was very important. We started many leadership initiatives. So when you look at it, you have FLAME on the left, which is the Female Leadership Initiative for bringing female academicians to take charge of department as leaders. We started the International Council for Critical Emergency Sonography because we use sonography as a visual stethoscope. We started teaching that. So, you know, something new brings energy, brings enthusiasm. We want to learn something new. You have to give something to attract them. Like cardiologists have intervention, like gastroenterologists have endoscopy. You needed to give something to make them feel that there was something going on in emergency medicine. We start trauma surgeons together because emergency medicine is incomplete without surgical backing. So we needed to bring their egos together and make them happy and make them feel that there are people who will work with them. So the trauma surgeons were brought under the trauma council and said, we'll develop emergency medicine, we'll also develop trauma surgery as a specialty for you, free. So they were very happy that they were getting something free. They joined the movement. Then we brought a policy cell together to be able to talk to the government. So we had some doctors who were politicians' children. We changed them and we trained them how to do the reeling and dealing and talking to the politicians, and we brought them under the advocacy group. MCORD is on the lines of CORD in US, the Council of Residency Directors. We started the Emergency Medicine Council of Residency Departments, and all the residency departments used to meet and huddle. Then we launched an association where there were no membership fees, 0 membership fees. Anybody and everybody could join the mission, free of cost, no money needed. Electronic software, go on the mobile, click, you are a member. You have to be a doctor though, or a nurse to be joining the association, but no membership fees. We started a network of research institutions. So we got one single IRB, one study. A unique thing in India which we are doing right now is that all postgraduate residents who study have to do a thesis topic. You cannot get your boards if you don't submit a thesis. What was happening is children were doing thesis which were not at all impacting anything, just for the namesake. Study of 10 patients, study of 20 patients, for the requirement of scholarly activity. We passed a rule last week, one nation, one study. So the central agency, our NIH, is going to create 7 big projects, and all the residents have to pick one of the 7 projects and feed data into the national database, and they will get credit. And we will get big data and we'll get big studies which impact. So we are running the pilot next year called One Nation, One Study protocol, and it will be one IRB, and everybody will have to register their institutions and feed the data set. The research was multi-centered. We did translation. We opened the first center of translational research where we are mapping the basic science genetics of shock. So shock research in the United States is a very big thing. I don't know how many of you are aware, but millions have been awarded to shock research in Alabama, in New Jersey, researchers who study the immunology of shock inflammation. Shock is one of our most important factors in emergency medicine, which is resuscitation. And we needed to bring basic scientists. So we created a signature program where a clinician will work with a basic scientist, where we'll study in the laboratory and see the application in patients. And our studies are now published in international journals where we have defined that if you give estrogen to a male who is in shock, you have better outcomes, because females fare better in shock because of the monthly menstruation, which trains them to be event memory hypothesis of immunology, where it trains the body. So if you use the same hormone in males, it helps. And these are the kind of path-breaking studies we have been able to define through our translational agenda. We did research by bringing scientists from basic science together, and now we are also doing public health research. So it's a signature program. You can work clinician public health, clinician basic science, or basic science, clinician public health, everything together. That's how we do it. Multiple papers have been published. We started our own journal. Every specialty needs their own journal. Definition of international journal in India used to be an American journal or a European journal in an Indian library. But why can't it be an Indian journal in an American library or in a European library? So we launched the journal from India, which got indexed in PubMed within 2 years. And its PubMed index, we have 500,000 readers across the world. And from this journal, we expanded to 15 more publications which we own. Most of them are indexed in PubMed. And we could create a full portfolio of publication line. So imagine our authors, our reviewers, our whole market footprint is over 1 million across the world through internet. Last year we launched American College of Academic International Medicine, which we are partners, and we helped launch the International Journal of Academic Medicine, which is on its way to PubMed too. The public health agenda needed that people be trained in CPR in the community, that's BLS. People be trained how to stop blood. This Stop the Blood campaign which came here, we have been doing it for 7 years now. And how to put a C-collar, how to get the patients on. And this has been endorsed by the WHO of the CRO region. Plus, we started something called as airway training for all. Every doctor who graduates from a med school needs to know how to manage an airway. And that was most important because people were not knowing how to manage an airway, and we had to get standardized protocols for airway management. One thing which lacked when I was studying was that I used to see Joint Commission coming and giving these star ratings to the hospital. Oh, star in orthopedic care by Joint Commission, star in cardiology by Joint Commission. Have you seen that? When you go to hospital, we are Joint Commission accredited, but we have special status in cardiology. We have special status in orthopedics. There was no status for emergency care. Joint Commission never says you are a 7-star department of emergency medicine, because we as a specialty never tried to get that certificate through. And it was very difficult to do it in the US. So I went to India, and the Indian JCI, which is our NABH, which is a part of the Quality Council of the world. They have a federation of quality councils of all countries. And I got this certificate passed there. Now it's being put in the international council, which JCI will take it in a couple of years from the main server. So now all emergency departments have to go through this certification if they are postgraduate, and it's a 56-page document where every benchmark is looked at like Joint Commission of how to develop it, but it's the tailor-made approach to India. In 2016, there were about 150 plus residency spots. 15,000 delegates were taught in 15 years, 10,000 hours of training, 250 workshops. We created many leaders. SUNY Downstate played a major role. Dr. Arkula, Sari, Manish, Dr. Anderson, everybody comes together every year to have our conferences. We have networks, college, nursing, leadership council. We started the first board review, which is taught in India like we do it in the US. We have a board review in India too. There's the Emergency Medicine Association. We have blogs, newsletters. Now what happened is after we did work in India for 10 to 12 years, many international faculty started coming from across the world to our conference. They said, we love this model. We want to take it to our country. So then we said, okay, fine, let's launch the World Academic Council of Emergency Medicine. So from this, we launched the World Academic Council, which was a non-political model. Like the political model is Society of Emergency Medicine US, Society England, Society Australia come together, sit across the table, and the politicians who win elections can speak in these international forums. We said, no, this is the open door policy. Whoever is an academician, maybe Japan, maybe Singapore, maybe Africa, wherever, can be a part of the World Council. You can be a member as an individual or an institution. And that changed the dialogue completely. And in 2015, we launched the World Council. And last year, we did the conference in Colombo, Sri Lanka. And this year, we are doing it in Qatar. And next year, we'll meet in Dubai. And now, it's spreading across the world that the world arm of our program is now taking roots. So our mission till 2025 is clinical and translational innovation, make partnerships globally. We want to bring electronic medical records across the country to be standardized. That's most important, to be able to track things. We want to teach basic emergency care to the community, which is endorsed by WHO, patient safety, which we have the quality certification. We have point of care technology, that's the bedside laboratory for troponin and BNP, everything to be developed at the bedside, simulation and sonography to be developed, and emergency care for all, fully insured by the government by 2025, and make sure that the residents who graduate have a good economic advantage and a career once they leave their residency. They need a job, they need to be settled, and they need to progress. The future initiatives is the World Academic Council and of course our investment in the American College of Academic International Medicine, which you are seeing. So if you see the program, we started with a small nidus to develop a residency program, landed up with a nursing council, a college, a residency, a journals, a newsletter, a rotations, not even stopping there, but a World Academic Council, websites, board reviews, research articles, leaving footprints locally and globally, to a fact that our ideology expanded, that we established the American College to bring international clinicians from every specialty under one roof. Everybody talks about public health. Nobody talks about clinicians working internationally to impact patient care. A clinician can do public health, but a public health cannot become a clinician. These are two different ideologies. And the clinical engagement internationally is the true representation of American healthcare worldwide. An American clinician, an academician working on an international corridor is an ambassador of America's patient safety agenda worldwide. And we needed that conversation to start, and that's why ACAIM was born. Our conferences, you can see, we'll meet in October in Qatar, and this was 2018, we are meeting here. So thank you very much, and this is our work in Asia. This is how we do it, and that's our website. So many people attend the conference every year, and these are the multiple websites with our journals, with all the work we have been doing. So everything which you need in academics is there. No photograph sessions, no photo sessions, no showing a country down, working together, increasing research, education, patient care, creating leaders who can publish, taking a country to that level that they can talk to the whole world. I think that's transformation. Thank you very much. Yeah, that goes to the video.
Ah, to the video. Yeah. Thank you. So, for those of you who do not know me, my name is Manish Garg. I am honored to have an opportunity to speak to you today. Also an honor to serve in ACAIM with you. I'm thrilled that I had a chance to speak with Rich and with Sagar. I'm going to switch gears a little bit and talk about program models and innovations to and from LMICs, but looking at the medical student international electives. So I really think that I've been very lucky and I've embraced serendipity in my life. I, like many of you, just wanted to get into medicine really to help people. I know they tell you on your entrance things, you don't tell them you want to help people because then you'll never get into medical school, but that's really just all I wanted to do. And you know, why do people come to the hospital? Why do they seek health care? Well, you seek it for pain or for infection. And if you got infection, you got pain. And so I worked in infectious diseases. I have a grant with the CDC and the NIH looking at emerging infectious diseases in the emergency department. So with emergency medicine, global medicine, and infectious disease, it kind of all came together. And got some Temple students in the back there. You all came to me when I was early in my career and said, you know what, we would love to have somebody show us the way of global medicine. And that's kind of how I got here. And then I got to meet all of you, and man, isn't this grand? This is just great what we do. I mean, the only thing luckier I always tell is the fact that I got to marry the woman of my dreams. So my learning objectives are simple. I'm just going to talk about to and from, all right? To LMICs and from LMICs, what are the lessons that we've learned? So when I was trying to come up with the correct model for academic international medicine for the medical school, we had a ton of students who wanted to go out. The original things that folks did was they went out to different countries. It was hit or miss in terms of what type of supervision they had. They basically had no preparation. It was whatever they had learned in med school to that point. And you know, in the beginning, I mean, well, we all remember we're learning our basic sciences. You start off with anatomy and you kind of continue and you go from there, right? And so I thought to myself, what would be the best way to prepare our students before they go globally? So I looked at what the World Health Organization had for Sustainable Development Goals. I looked at the CDC's site for global medicine and global health and looked at the topmost kind of burdens of disease throughout the world. Because let's face it, you know, if it's HIV or TB or even something like malaria, think about how much time in medical school you had covering malaria. Yet think about the actual burden globally for malaria. In addition to that, child and infant mortality, you know, sustainability. We've talked about that, and we had a really great talk that Rich just gave about sustainability. And these are the concepts that I wanted to make sure that our students and then also our residents had before they went abroad. So we put together a global health elective, and it was very, very well received. Of the 200 students who would matriculate to Temple Medical School every year, I had about 150 in our elective, of which 50 were upset that they couldn't be there. And maybe there was about 10 that didn't have any interest whatsoever. And so I wanted to give you just like an example, because I think one of the nice things about a program like this and a conference like this is we can share our regulatory documents. We can share some of our systems that we've done that have been successful. So I kind of broke it down into educational talks. And it talked about disaster, emergency medicine, talked about public health in the field, maternal, orthopedic, wound care, microbiology in the field, malaria, HIV, TB, these hugely burdensome infectious disease processes. And then we made workshops, like how do you understand physical diagnoses clues while you're abroad? How do you write prescriptions and soap notes? Now I know things are electronic now in this country, but folks still need to write. And I can just as easy have a medical student write a prescription for amoxicillin just like I can for an anti-malarial. How to create and present a global health talk. Also to talk a little bit about developing them as a professional. And then some skill sessions. IV placement, which I joke around was like, you know, bone marrow biopsies when we first started, and then it slowly got better and better as time went on. You know, delivering babies, obviously through SIM, pelvic exams, laceration repair, orthopedic care, emergency care. So all of a sudden we're transforming baby delivering here so that when they go out, they had an opportunity to do it for real. Now, of course, we did the baby delivering, they were observing, but you know, they had an opportunity to be there, and this is like the first baby that we had delivered in Ghana with Temple. Writing the soap notes and writing out the prescriptions. These are our first years at the end of their first year being able to write, of course supervised by us attending physicians, but being able to write notes. And then orthopedic care, and then taking care of children abroad. And the concept was that I can take a first or second year medical student with really, really good didactic training and give them a meaningful experience when they go out. And I thought that was critical for how we did this. Because the question that I always got from the deans or from the leadership of a medical school was, well, they're first year and second year medical students. What can they really do out there? I think they can do anything as long as you empower folks. How many students do we have? So if you have a program that was like this, it was 14 contact hours and then continual talks that we had throughout the medical school. I gave a 1-hour talk as part of the curriculum about global medicine. We were able to make students have very meaningful experiences abroad. All right, and what we got, so that was kind of the 2 going out there. Well, what we got was the greatest gift we could ever possibly imagine, that the LMICs reciprocated back to us. And I mean, Sagar just mentioned, you know, all of the work that happened with INDUS-EM. It was an amazing thing that we were able to partner together because our students that go out to these sites are having incredible experiences. And the quality, based on education, clinical care, and research, that model, that shines through in all of the didactics that the students are getting while they're out there. And that, to me, is critically important. Because when I had students going out to some of the other sites previously, you know, the educational quality or even just the organization was hit or miss. But through LMICs that had the ability to develop, adapt, and put together programs that on many levels are better than things that we're doing here, we're learning a lot of lessons from the LMICs. You know, they say there's no luck, right? You talk to a football coach, and they'll say luck is when preparation meets opportunity, right? So what kinds of things did the students take from these experiences? Well, this beautiful little girl here came to us seizing while we were doing the consultation room in Ghana, and she had cerebral malaria, and we were able to establish an IV right away, gave some anti-epileptics. We were able to start anti-malarials right off the bat, and in 3 days she was back to her normal baseline, and that's her mother. I mean, those are the kinds of differences, and I know we'd make those same kinds of differences in our countries here, wherever we are, but that kind of difference for the medical students really was empowering for them to see, like, hey, you really made this difference in this person's life, you changed the trajectory, and this all came because you came out to a place which didn't have the same sort of background. So they had an emergency department. These folks happened to come to us in the consultation room, and just by chance that we happened to be working there, they came there and they came in with a single IV that we were able to start. Flashpoints in healthcare delivery. So this wonderful person, now I didn't know what his diagnosis was when I first met him. I took a picture with him. He ended up, and if you read the note that our medical student wrote, ended up having loss of weight, fevers. He came in febrile, tachycardic to 136, this gigantic lump on the side, difficulty breathing. And it was the first time that our students ever had to diagnose a patient internationally with both HIV and TB. And what was really the flashpoint, or what was most shocking, was after both the students and myself made the diagnosis and wanted to start therapy, the hospital administrators came to us and said, we can't admit this patient. We don't have a TB ward upstairs. If this patient is admitted in our hospital, they're going to kill the rest of the patients. And it was one of those moments that was shocking, because often we might think of HIV or TB as a chronic disease, not a death sentence. And so that flashpoint for the students, that the best care for this patient was that they would go out and go back to the home and spend their meaningful time with their family, was something that I know that will last with them forever. Also, systems-based practice. Anybody in residency program training, or even just medical student education, right? So, you know, the one that we never can teach medical students and residents as effectively as all the other competencies for graduate medical education is systems-based practice. It's resource utilization, it's understanding operations and flow. So this is us in El Salvador, and we've got like our attending physician here, we've got tables with students that were initially doing the intake, junior student, senior student, excuse me, Spanish speaking, and we would kind of go around, we had patients kind of assembled in what was like a collection so we could do public service announcements there and do some charlas and some teaching, and then an area that was like a launching pad so we could help identify people who were sick as they were coming in. And so one of the things that the students were able to learn that they never got a chance to do while they were, you know, in our kind of Temple hospital, was they got an opportunity to set up clinics and set up healthcare delivery, which is something that, you know, from an operational standpoint and a systems-based practice standpoint is incredible. And so we would go through these different scenarios where we would say, hey, you know, you've got 80 people that you're supposed to put together, 14 tables, 80 chairs and maybe one fan, and how are you going to put together a room? And so the concept or the thought that you would be taking care of not just patients and having medical debriefing sessions following, but also the concept that you would have to understand how to assemble tables, how to understand unidirectional flow, know where your pharmacy was, having a private room. That operational system enhanced their medical care. So systems-based practice, that concept is something that I talk to deans about in my role as Director of Global Medicine to try to explain this is an actually very important aspect of care, and it'll help the folks that are down the street. But we also had a lot of program challenges because there were some huge things that happened that I did not anticipate as somebody who was in this role. So this was just, you know, a few weeks ago. I had a trip that was scheduled to go to Nicaragua, and they went, and there was all sorts of protests politically. The State Department recommendation went from a threat level 2 to a threat level 3. I had created policy before that if through the school, that if a place had a threat level 3 or 4, that we weren't going to be sending our students there, because we have to respond to parents, we have to respond to deans, we have to respond and be accountable for the members of our community. So when this happened, we learned a lot about the organization that we were partnering with. Now, I'm not going to name that organization, but they had set up a 501(c)(3). And so if you donated money to the organization, they kept it. There was no way to return or refund the money. So they basically said, yes, we keep your money and you come on the trip, but if you can't make the trip, we just keep your money. And so that was kind of an interesting thing in terms of financial modeling for the students to learn, and also for me, in my role, to learn, like, okay, we need to really understand how the financial implications will affect our future trips and our current trips. Thankfully, we were able to find another group that was going out a few months later, and we were able to transfer the money to them, so the students got their money back, and I didn't have angry parents. Also, safety was an issue. When we first started this, we've had medical students robbed at gunpoint, and also important things stolen because people were flashing cameras. They just weren't exhibiting vigilance. And so part of the process was for me to come up and figure out in our program model that I needed to have a safety discussion with all of the students before they go. So safety discussion while they're there, professional safety, personal safety. Finally, in this last year, and this was something that thankfully Sagar was able to help with, Contagion, the movie. You know what that movie is based off of? Which virus? It's based off the Nipah virus. Well, our partnership that was at Jubilee Hospital that's in Kerala is amazing, and I'll talk about it a little bit later. That Nipah virus outbreak was just a couple towns over. So thankfully, because Sagar has this network, we were able to put our students to a different spoke in the network. And they're having a fantastic time. I think they just got back. I've got all the pictures, and the didactic programming that they put together because of the organization was incredible. Flash forward, these students are learning about Ebola, they're learning about HIV, they're learning about Zika virus, all of these things that are representative out there that they have questions as they're going on future trips. So it actually helps them with future trips. And also, what are they learning? Well, we've got patients that they're taking care of. This beautiful young girl's got, sadly, has got kwashiorkor. And we were here in Ghana at the Princess Maria Louise Hospital, where they actually coined the phrase kwashiorkor. It actually comes from that hospital. But one of the things that blew my mind is how they do nutritional rehabilitation there. They admit patients for nutritional rehab. They then start them on a certain type of, like less fortified, like 80% milk, advance them up to milk, give them the plumpy nut, the World Health Organization food. Meanwhile, they teach the parents about dieting and about what type of grains and what types of foods to provide their children. So it's kind of like a family gets admitted for this process, which I think is amazing, and it's a really great LMIC innovation. And so what did we do? We published that with them. And just to talk about some of the concepts and some of the things that they did. And we thought that this was a remarkable innovation that they were a part of. And then similarly, we also wanted to say, hey, what about growth curves and pediatric growth curves for boys and girls, whether you had insurance or whether you didn't? And one of the things that we found from this study that we put together with the medical students was that if you were a girl and you didn't have insurance, you actually, unfortunately and sadly, started to fall off the growth curve. And so we were able to advocate for the students, and the doctors and the team there were thrilled that, hey, we've got some data now, and now we can go back and talk to our politicians about why it's so important that everybody get insurance. And then, we were able to teach public health, and that was also one of those flashpoint or touchstone moments for our students, that they were learning public health in other countries. The Ghanaian public health, child health records has all of the stuff you need to know for malaria, all of your immunizations that are in there, all of these different sequences. And frankly, these little books were very helpful. It was like every parent had one of these books as they were walking around. And they were also able to understand about some of the public health crises, as they did such a good job about signage. We did some disaster PPE and hazard work as well. So our students were here again, training and learning in our session, and then we were able to help some of the hospitals put together a disaster program, which was very helpful. And at Jubilee Hospital, they have a holistic integrative medicine program that's there, and that's something that's not talked about, and it's a gap in our healthcare. So I felt like the students were able to really gain a lot of program innovations from the LMICs. And one of the cool things that Temple does is they have, the medical school has a Pulitzer Prize winning narrative medicine expert. And two of our folks just went, two of our students who were here, Janie and Joe, went to Puerto Rico, and they put together a whole series of different essays and poems and experiences. And these are all things that, you know, show how important the impact is from the LMICs and from these different international experiences. So, you know, I can send out this link, but these are really exceptional, like moving pieces that'll get you excited about medicine, and also speak to your deans and speak to the people in charge about why this is critically important and why it's important that we look and see what the LMICs have to offer. So in summary, I feel like ACAIM as a group has a lot to offer in terms of its partnerships. We've benefited as much from our LMIC exposures. Remember, our goal is not just to have bilateral interactions, but multinational interactions. Can we get something together where we are helping our outfits and our groups go into places where multiple different universities and learning centers are involved, and then can we turn that into something bigger for everybody? So I thank you very much. And we can take some questions if there's any time. No, we can't. Oh, I guess we can't. Sorry about that.
We do posters, but maybe some offline questions.
Maybe some offline questions.
Before you leave, yeah. Get a couple words in quickly. Thank you so much to the three speakers of this session. One more round of applause for them. I'd like to give you your certificates, please, Sagar and Stan and Manish.
All together, all together.
Please take advantage of the lunch hour to check out the posters that are going to be up. The ones that are up today will only be up today, so please go ask questions, go check them out, see the great research that's being done in academic international medicine, and we'll see you guys at 2 o'clock for the next session.